Hello and welcome to the APAP podcast. With us today is Rebecca Priebe. She's a certified acute care nurse practitioner since 2009, and today she's going to talk to us about interventional pulmonology and how it applies to advanced practice providers. She's currently the lead nurse practitioner in interventional pulmonology at Henry Ford Health in Detroit, Michigan. Rebecca has been instrumental in the development of an inpatient interventional pulmonology consult service, expanding the advanced pleural services and initiating a bronchoscopic lung volume reduction program, which is currently the third largest program in the United States. Rebecca will assume the chair position of the American Association of Bronchology and Interventional Pulmonology's Advanced Practice Provider chapter in 2024. Congratulations. And today she's going to share everything she knows about interventional pulmonology, which I will tell you up until the last 2 years, I probably was pretty naive to the fact that there were APPs subspecializing in this area. So I'm very excited to have you with us and tell us all about it. First, can you tell us a little bit about the background of where interventional pulmonary APPs kind of started?
Yeah, well, thanks for having me. Excited to be here and talk about, my specialty because I love it. IP became a subspecialty probably about 25 years ago. The fellowship program was certified by the ACGME just not that long ago, a couple of years ago. And so advanced practice providers became a chapter and part of the program about 8 to 10 years ago. And so when I first started in IP, I think there was 8 of us total within the AABIP and people that I had to connect with. And now there's, 60 plus of us all around the United States.
And the AABIP is the American Association of Bronchology and Interventional Pulmonology, I'm assuming?
Yep.
All right. They have their own APP chapter.
They do. Yep.
That's awesome. That is so awesome.
Yeah.
So for anybody listening, if you want to go to their website and check it out, if you're doing interventional pulmonology and may not for some reason know about this or want to get into it. Well, speaking of getting into it, how do you get into interventional pulmonology? If you're a procedural person and this sounds like kind of your bag of tricks, how do you get into it?
Yeah. Well, I happened to come about it just when I was looking for jobs. I was an ICU nurse practitioner and looking to do more procedures, and I had come across the posting, but it's such an advanced field now, and it is growing immensely. There's over 60 fellowship programs now within the United States, and they are popping up everywhere. Interventional pulmonology really encompasses not only just procedures, but programs. So there's lung volume reduction programs that are being started all over the United States, looking for coordinators and APPs for those programs. Lung nodules, it's including lung cancer screening programs now and big pleural programs. And so whatever kind of your interest is, IP is popping up everywhere.
Oh, wow. And now when you say fellowship programs, are those specifically for APPs, for physician fellows, for everyone?
Yeah, so physician fellows, that's what I was talking about. But there's one APP fellowship program for nurse practitioners and physician assistants at Beth Israel.
Oh, okay. Okay, wonderful.
Yeah.
All right. So could you describe a little bit the types of procedures that encompass an interventional pulmonary APP?
Yeah. So it varies between kind of institutions that you go to as far as, what your role is in interventional pulmonology as a advanced practice provider. Many of my colleagues are doing just, pleural programs. So they're doing pleural procedures like thoracentesis, thoracic ultrasound, indwelling pleural catheter placement, chest tube placements. And then there are, nurse practitioners that do just airway management. And so, we do assisting in the operating rooms for rigid bronchoscopies and pleuroscopy type procedures. There is a handful of us that do bronchoscopy and BALs at the bedside and assist with mostly bedside procedures where, patients are too sick to travel to bronchoscopy suites or endoscopy suites for their procedure. And so, we're being uptrained to be able to provide that procedure at the bedside.
When you were talking about lung nodule programs, are you guys involved in any of the biopsies for lung nodules or navigational bronchoscopies, that kind of thing?
Yeah, we do a lot of first assisting with those robotic navigational biopsies, transbronchial biopsies, radial EBUS, and that kind of thing. Yes. And then we help with the processing and stuff. A lot of the time, the advanced practice providers are, essentially running those programs. So they're, meeting with the patients, doing educational seminars, following these patients, seeing them in clinic, monitoring these lung nodules, and then sending them for us biopsies and stuff like that.
Okay. Do you guys run into any scope issues with so you're in Michigan? Do you run into any issues with scope of practice?
So it's it can be challenging. When we there's a handful of us who started doing bronchoscopy, and kind of that's not anywhere in anyone's scope of practice or state recognized. And so you can come into some of those problems with the support of other nurse practitioners or PAs that have gone through that. We've been able to formulate training programs and processes to get certification within our institution.
Oh, that's nice. So credentialing would really come down to the institution you're at.
Yes. Yeah.
Okay.
So the institution, for example, that I'm at for, let's say, bronchoscopy, we have a simulation lab. You have to do, 40 simulated bronchoscopies on the sim, and then you go into the bronch suite and you do your airway exams and stuff there and get checked off with whoever your preceptor is there. Some institutions have you have to do 50 bronchs in order to be certified, but it really is, the practice is changing where it's, whenever you're comfortable and you kind of, mastered, that particular procedure is kind of when you've been, signed off and credentialed for it.
Does the AABPI, I think of all the letters, do they have any type of certification program for you guys, or any type of
No, not for APPs. We are working on publishing a curriculum training program for advanced practice providers and IP. And so we're just kind of going through the edits for publication still. And then, like I said, Beth Israel has a fellowship program for interventional pulmonology and critical care. And so it's a 1-year fellowship training program that's run by APPs and it encompasses the IP program there.
Wow. I think that'd be a great resource for maybe people that aren't doing specifically IP, but are working in the ICU and need to have a training curriculum for their APPs that are doing procedures in the ICU. I think that would be a pretty cool crossover tool. So yes. When do you think that might be available?
Hopefully soon, in the next couple of months. It should hopefully be published, I hope.
Oh, that's wonderful. That's wonderful.
Yeah.
All right. Well, I imagine to get some of these programs going, you have to have a lot of physician support and backing to make that happen. Any advice you would give to APPs who are maybe they're doing procedures already, they're looking to advance into a sole IP role, how to make that happen?
Yeah, it really is. I've been fortunate to find a really good group of physicians who've really took me under their wing as their first nurse practitioner or APP ever to really, give me the autonomy and give me the education I need to be autonomous for them. You can be overworked in any field, especially with IP. You work alone a lot of the times or just with physicians. And so it is really finding someone who wants to spend the time to uptrain you, round with you, teach you, and, give you that solid time.
Yeah, I imagine that is a pretty bonding experience with that physician.
Yes.
Yeah, a lot of time with them. So are there issues with billing are you billing for your procedures? Do you have a supervising physician that you're billing, like a shared visit through, or?
Yeah, so I work in both an inpatient and an outpatient role. So for inpatients, when I see like new inpatient consults or write progress notes or do any procedures, I bill by time instead of medical decision making. And so I bill that by time, and I send it to whatever physician is staffed that day. We kind of review cases verbally. I have them see the patients if I feel like it's something that they need to see, or I'm concerned about the patient, I'll make them come and see the patient. But it's really building. I bill autonomously by time, and as well as in the outpatient setting. I have my own half-day clinic by myself. There's no physician staff, and so those 6 patients that I see in an afternoon, I bill by time, and then just get that 80% billing, which is what our reimbursement is for NPs.
Yeah. Do you do procedures in the outpatient setting also, or are you just seeing your follow-up patients?
Yeah, I'll do, I'll get called by oncology that like there's a patient in their clinic that has an effusion, he's short of breath. It's like a Friday afternoon. And so I'll just go to their clinic and, do procedures just, for good continuity, good patient care to try to keep patients out of the hospital. So yeah, I'll go to clinics, or they can come to my clinic as well. But it's just easier to go take your stuff with you and go.
Yeah, we started doing thoracentesis in the clinic about 8-10 years ago, when those little tiny GE ultrasound machines came out.
Oh yeah,
so that we could do ultrasound in the office, and it was a game changer. And let me tell you, I've never been more popular with the oncologists until we started doing that.
I know, they love it.
Yeah. Oh yeah. They're texting you, calling you. I've got a patient here. Could you just squeeze in a tap today? Of course. Yeah.
Wow.
Yeah.
It's just easier to go there instead of like bringing them to the Bronx suite or something like that. So,
yeah.
But yeah, we do a lot of, we send a lot of patients home with chest tubes. And so we'll send them home on like an outpatient chest tube, one-way device, whether it's a Heimlich or a mini atrium or something. And so I'll do a lot of chest tube management in my clinics, as far as if it's ready to be removed or, stuff like that. But yeah, a lot of it's just thoracentesis or pleural ultrasound.
Okay. Are you doing outpatient pleural catheters?
Yeah, we do that all. They come to our bronchoscopy suite. And so, we, in the bronchoscopy suite, I do work with a physician there. And so we have like a pleural room, and then we have 2 bronch rooms. And so let's say I'm in the pleural room that day, they'll come in and like see my spot and, say hi to the patient, that kind of thing. But yeah, we can, we do those chest tubes, indwelling pleural catheters, thoracentesis, all in that pleural room.
That's pretty neat. I imagine reimbursement for procedures pays a little bit better than just a plain old office visit. Do you feel like that reflects in your salary? I mean, because I don't know if we have any information, or if your board within AABIP IP has, if they have information about salary data. But would you say that salary tends to be better or the same as those not doing procedures?
I would say it's better. When I compare my salary to other APPs within my institution, because I'm a specialty service and it's like considered a procedural surgical service, it's definitely like a tier 3 as far as pay goes. We looked at, we use my revenue, that what I bring in from my office notes and inpatient notes and procedures, to get more staff. So I just had another nurse practitioner start on Monday who is with the IP service. So then it gives us more flex to, me do more clinical research or stuff like that. We got another coordinator because our BLVR program, blew up. And so we use a lot of that kind of revenue. But I mean, I get a raise every 6 months, and I can't complain. And I really enjoy my job. So
oh yeah, that's great. Do you feel when you're in the ICU? Let me rephrase that. When you're in the ICU doing procedures, you're not managing the case otherwise? You're just a specialty service consulted by the critical care service to come in and do procedures?
Correct. So we have 120 medical ICU beds in our institution. And then we have like 70 surgical ICU beds. Our interventional radiology is really small, and so they won't let ICU patients travel to them for pleural stuff that we can take care of. So yeah, we have a pretty large, I probably do about 50 to 60 procedures at the bedside every month, and just travel to the ICU for it. But yeah, we're just consultants. You try to stay in your lane by just coming in, doing the procedure, and then, making recommendations if it's pertinent to whatever you're doing.
Mm-hmm.
As far as, we follow up on cultures. And then if we have to do biopsies at the bedside, we follow the path and make sure they know if the path is back and that kind of stuff. But no, I really, we let the critical care people do their thing. As far as overall management, we do our consultant stuff.
Okay. Do you ever get involved in central lines or lines at all, or is it just mainly chest and pleural procedures?
Yeah. Well, I can do them, the art lines and central lines and stuff, because I was an ICU provider, but I try to stick to just the pulmonary stuff at this point.
Okay. All right. Any other procedures that we didn't cover that you guys do, either inpatient or outpatient?
Well, interventional pulmonology itself does like hundreds of procedures as far as, we're the management of advanced airway and pleural disease. And so we do trach placements, exchanges, decannulation. We do all management of malignant central airway obstruction, so rigid bronchoscopy with tumor debulking. We use lasers and other forms of thermal ablation. We do airway stenting and tracheal stenting for various issues like tracheal stenosis from intubation traumas. And we do bronchial thermoplasty for severe asthma. And then we do valves for not only COPD patients, but for persistent air leaks that, and these are all patients who are non-surgical patients. So they're really sick patients. And then as far as pleural disease, we do similar to what thoracic surgeons do, minus VATS type procedure or big decortications, but we do pleuroscopy, pleural biopsies, pleurodesis. I'll go to the bedside and do interpleural lytics via chest tube for empyemas, and, TELC or, whatever kind of pleurodesis via chest tube that's, indicated. So yeah, we do a wide range of things. It's never a boring day, that's for sure.
It sounds like it. And you don't have to get called with all the low potassium issues and
no.
everything. Very nice.
Thank God.
Well, with all those
true.
procedures, there's always risk, right? So do you, a lot of times advanced practice providers are riders on their physician group's malpractice plans. Do you carry your own individual malpractice, or is it still just a rider situation?
Yeah, I don't carry my own. I had thought about it for a while and had some, especially when I started going to more procedural stuff. And I had, talked with some advisors about it and was advised against it as far as, if you have your own, then, they can actually go, they can actually go after you as an individual and if you're not on a rider. So I'm part of my institutions, my medical groups. And, I have been part of a lawsuit. And it was great. It was fine. I had really great support from my physicians. And so yeah, I don't have my own.
Okay. I was just always wondered that with doing so many procedures, if that was going to be, a separate issue there. Do you have any favorite procedures, ones that you really enjoyed doing?
I really, I've been bronching for probably about the past year, so it's kind of newish. And I enjoy it. It's to the point where, people call you because they know you're around and you get really good at doing, like I can put a chest tube in about 10 minutes. So you get really good at it. And so I'm doing a lot more teaching now. And like, I'll go to the unit and the fellow will be like, can you teach me how to do a chest tube or, do a thorough while someone's in the bed and not sitting up. And, so it's a lot more, educational now, which I enjoy. So.
Oh, that's good.
Yeah.
Any resources you would like to share with people listening that maybe want to take a deeper dive into the procedures they're already doing, or maybe figure out how to start doing procedures like bronchoscopies? We introduced that to our APP ICU team pretty quickly once it was developed for bedside, ICU management, maybe, for atelectasis or, mucus plugging and, that kind of thing. Not so far, we're not doing anything diagnostic, but they were very excited and early adapters to learn that type of information, and they want more, So do you have resources that people could go to take a deeper dive?
Yeah, the AABIP, the APP chapter, we're a very close-knit community because there's not that many of us. So we do a lot of like education sharing, patient education sharing, videos that we've done for patients and that kind of stuff. So it's a great resource. Your chapter as well has really great resources on there. So I've looked at that. And then really it's just, because IP is so small or, procedural people are so small, it is really looking to your mentors, your physician mentors to kind of help you in the right directions. There's a lot of really good IP online books and resources. But yeah, you just kind of have to, trust your mentor to lead you in the right path. I've been really lucky, and a lot of my colleagues have been too. IP, the physicians are amazing. They're very, we use a lot of AI and technology, and, we're starting into the cone beam world and cryobiopsies. And so there's so much excitement in the field. They're looking for APPs to join all of their teams. And so I can see it expanding a lot for advanced practice providers in the next, 5 years for sure.
That's pretty exciting. It's a very exciting time to be in pulmonary in general. New medications across the board. If I'm in general pulmonology, and so, we treat it all, and it's been very exciting, especially in those lung cancer patients, as well. When I started 100 years ago, we didn't have any chemo. We had nothing.
I know.
Radiation, lobectomy, hospice.
I think SBRT was like a thing, but it was like a death sentence. And now it's like we can biopsy these nodules that are 2 millimeters, and like it's curative for these patients. And so I think these programs are going to be like standard of care for reimbursement for Medicare and Medicaid. I think that's coming down the pipe. I mean, when we launched our lung cancer screening program, we have 7 APPs that were hired to it. We diagnosed 80 new cancers in a month.
Oh, wow.
And so it's just been like expanding and expanding. And so, I think it's going to be life-changing for patients. I mean, and then like sleep apnea and central sleep apnea, like, and end-stage COPD with now NIVs and AVAPs. And I mean, we didn't have any of that 15, 20 years ago when I started. And so it's crazy.
Yeah, it's
wonderful.
Very exciting to be here, and especially as APPs in the field, because we're getting noticed.
Yeah,
industry's noticing us, that type of thing. So we need to get more people involved and passionate like you. And so I'm so thankful you agreed to come on today and share your information with us, and hopefully we can get others out there to use those resources as part of APAP. Once you have your resources, for onboarding. We would love to share that with our members as well. So
sounds great.
Go look at the website. So, well, thank you again, Rebecca. I so appreciate your time of sharing that with us. Thank you for kind of forging the way in this new field, and good luck on your chair position in 24. And we hope to do some other programs with you.
All right. Thanks.